type 1, type 2 and type 3. There is a minimal, no displacement, minimal displacement and displacement more than 5 mm. So imaging we know, we can see in AP and lateral view of X-ray. We can do the stress X-ray. We can see that there is a chip fracture of the TBL, posterior tibial spine. In CT scan is very important. We can see the communication of the fragment, and MRI we know. With help of MRI we can know the other injuries, osteochondral defect, injuries and meniscal injuries. So what is the treatment of the PCL avulsion? There are currently variety of treatment approaches for PCL avulsion, but none emerging for as a gold standard technique. The treatment option depends on the type and size of the fracture, the amount of displacement, amount of comminution, and concomitant injuries. So PCL avulsion injuries occurs in young active patient. It is generally recommended that displaced avulsion fractures should be reduced and fixed in timely fashion to stabilize the joint and prevent non-union. So there is an option like non-operative treatment. We can immobilize in the cast or in a brace with a with PCL pad or anterior extension, dynamic extension brace for the 6 weeks, then limited weight bearing, and then rehab. So it may heal, but it is used only for less than 5 mm displacement. So another is open and arthroscopic. So I will talk on arthroscopic, the Shetty sir will talk on open reduction. So directly going on, so my technique is a surgical pull-through sutured method. So this is the same case I am going to present. This is MRI and this is a pre-op. We can see the posterior drawer test before doing the, and we can do the all test about whether there is M-cell injury, whether there is any retinocular tear. We can see after, we can operate this PCL avulsion in after 1 or 2 weeks like that. This is arthroscopic finding. You can see this is a lax, PCL is lax, and this is a slow PACL sign. We can do the anterior drawer while doing the scopy. So we can see we can take the tibia forward. So after I am using this with the 4 portals, anteromedial, anterolateral, posteromedial and posterolateral portal. Posterolateral portal is a weaving portal, posteromedial portal is a working portal. So we can see this fragment, assessment fragment. In this case, we can see there is a articular surface of the tibia is also involved, and the whole PCL ligament. We can see we can prepare the tibial fracture bed and debride that, curate that. We can assess. Then next step is I can, with the help of fast mini, I can put the one suture tape through the PCL substance, and I can another suture tape I can give the loop. So 2 suture tape on both sides. I am using a 2-tunnel technique for this. Previously, Padiwala sir was using a 1-tunnel suture loop directly pull through technique, but this I am using a 2-tunnel technique. This is how we can put with help of PCL jig, we can put 2 guide wire. You can see here guide wire. This is one guide wire is here. I am not using 4 mm drill for only 2 guide wire I am using below the fracture line, below the fracture bed, just below the fracture, 1 or 2 mm below the fracture on both sides, medial and lateral side on the fracture bed. Then this is the help of guide wire. These are the 2 guide wire. We can see with distance of at least almost inch. And this the suture management we can do with help of any suture retrieval, both sides from the both hole guide wire. We can just take out this 2 suture tape anteriorly and fix it on this is the final fixation. We can see the robust fixation of the PCL avulsion. The whole bed is covered, and this side is one guide wire, one suture tape, and another side suture tape. This is one side, and this is the lateral side. We can see where the fracture is well fixed, and this is we can see from the anterior side. Now PCL became taut, ACL also became taut. The slow PACL sign gone. This is how we can do fix the suture disc keeping the knee in almost 70-degree flexion, giving the anterior drawer, and then tighten this sutures. And we can see the stability after the fixation of the PCA. And this is a special brace with, this is a long knee brace with special PCL pad to prevent the subluxation of the tibia, proximal tibia in the knee brace. So we have to give this PCL pad for 6 weeks, limited non-weight bearing. Then we can start weight bearing. We can give the anterior. We can start a CPM after 3 weeks, but non-weight bearing, and prone flexion after 3 weeks. So advantage, this technique has several advantages. Posteromedial and posterolateral portals provide good visualization of the tibial bed with satisfactory access of instrumentation to debride and reduce and fix the fragment. The technique gives reliable fixation and prevent displacement of bony fragment, especially if fragments are small or comminuted. So coming to the open versus arthroscopic technique. So this Perry-O and Hooper et al. Did systematic review of 28 articles, and they included 637 patients, and in that they found that PCL injuries with the tibial side avulsions were result of road traffic accident in 68.4%, and in 59% of these injuries resulting from the motor vehicle accident. So the arthroscopic group had better IKDC grade A score, that is 78.9%, and indicating a normal knee post-operatively as compared with open group, that is 65.9%. Then post-operative Lisam score were similar between the two groups, but mean is 95 in arthroscopic group and 92 in open group. The arthroscopic group also reported 100% pre-injury level activity compared with 86.2% in open group. So discussion, I prefer operative fixation of any displaced tibial avulsion fracture. In our experience, suppose we wanted to do open reduction, so there should be large fragment as we are doing the posterior medial approach for the tibia or Buck-Shaper approach. We can give if there is a fragment is very large, we can do the open. But advantage of arthroscopic approach is a concomitant intra-articular injuries seen on perioperative MRI, such as meniscal tear or osteochondral loose fragments, can be addressed at the same time of the index operation. So conclusion, in patient with displaced tibial side PCL avulsion, treated operatively, surgical approach renders similar outcome and risks, while arthroscopic group had somehow higher subjective and objective knee courses. The clear advantage of the arthroscopic approach is a concomitant intra-articular injuries seen on pre-operative MRI, such as meniscal tear, osteochondral loose bodies, can be addressed at the same time of the index operation. Thank you.